ClevaLab. Mast cells line the tissues exposed to the outside world. They lie under the surface layer of cells in the skin, nasal cavity, stomach, intestines, and lungs. Mast cells also surround blood vessels and nerves. They originate from stem cells in the bone marrow and enter the blood as immature cells. They then migrate to the tissues where they mature into recognizable mast cells. Note that mast cells are distinct from basophils. Each mature mast cell contains hundreds of granules. These granules contain protein and chemical mediators. One role of mast cells is to protect the body from foreign invaders. They protect the body by detecting bacteria, viruses, parasites, venom, or physical harm. This detection is via their cell surface receptors. The most well-known mast cell receptor is the IgE antibody receptor, the Fc epsilon receptor 1. These receptors only exist on mast cells and basophils. The IgE antibody circulates through the body at minute levels. This low level is because the majority is bound to the IgE receptors. Mast cells also have other receptors. They can respond to IgG antibodies and components of bacteria and viruses. Within seconds of receptor binding, they can release their granules. The primary mediators released are histamine, tryptase, chymase, carboxypeptidase A, and heparin. These act on the surrounding tissues. They dilate blood vessels to slow the blood flow, as well as make the blood vessels more sticky for immune cells. These effects attract immune cells into the tissues. They make the blood vessels leaky, which allows antibodies to enter the tissues. The antibodies and immune cells neutralize and remove the infection or toxin. Once removed, mast cells make anti-inflammatory mediators. These stop further immune cells from entering the tissues. They also promote the rebuilding of tissue and removal of dead cells. The tissue returns to normal and the mast cell regranulates to be ready for future infection. But with so many granules ready to release at a moment's notice, it's easy to imagine how things can go wrong. An allergy is an overreaction of the immune system to the environment, and mast cells can cause many allergies, such as hayfever, asthma, food allergies, drug allergies, insect stings, and insect bites. Whether you develop any of these depends on both your genetics and the environment. So genetics alone is not enough. You also need exposure to the allergen via a broken barrier in your skin, intestine, or lungs. When allergens make it into the tissues, they activate the immune system. The activated immune system produces antibodies, including IgE. IgE antibodies bind to the IgE receptor on your mast cells and basophils. When you re-encounter the antigen, it binds to the IgE on the IgE receptor. This binding causes degranulation. Some people's mast cells will degranulate with less stimulation than is typical. This response can be due to increased amounts of IgE on each mast cell or other genetic differences. The mediators in granules released by mast cells cause classic allergy symptoms. The type of symptoms experienced will depend on the amount of allergen and where it enters the body. Inhaled allergen will cause sneezing, congestion, airway swelling, itchy eyes, wheezing, and coughing. An eaten allergen causes swelling in the mouth and esophagus, diarrhea, and vomiting. An allergen in contact with the skin causes redness, swelling, and itching. Also, inhaled and ingested allergens can cause dizziness from low blood pressure. Low blood pressure is caused by plasma moving into the tissues and blood vessel dilation. Food allergens can sometimes enter the blood via a leaky gut. Allergens circulating in the blood will cause hives or anaphylactic shock. Anaphylactic shock is when blood pressure becomes so low that there's no longer adequate blood supply to the organs. On top of this, swelling of the upper airway obstructs breathing and further reduces oxygen. Because of this, anaphylaxis is life-threatening and sometimes fatal. The body tries to compensate for low blood pressure by increasing the heart rate. But in extreme instances, this is not enough to prevent loss of oxygen to the brain and heart. As a result, the person will become unconscious and go into cardiac arrest. Giving adrenaline via an EpiPen in the early stages of an attack can reverse these symptoms. Adrenaline relaxes the airways, constricts the blood vessels, and increases heart rate. all of which increase blood pressure. Adequate blood pressure will ensure continued oxygen supply to the organs, so adrenaline in the early stages of anaphylaxis is life-saving. In some people, mast cells have DNA mutations. These cause them to be more reactive to known or unknown triggers. These mutations can be inherited or acquired over time. This overreactivity of mast cells is a feature of mast cell activation disorders. Examples of these are mast cell activation syndrome and systemic mastocytosis. Mast cell activation syndrome is present in up to 17% of people, which is very surprising. Unfortunately, this fact is not well known to GPs or even specialists, so people can go undiagnosed for decades. Symptoms can affect many organ systems. There can be low blood pressure, palpitations, fast heartbeat and near fainting, flushing, hives and itching of the skin, pain in the joints, osteoporosis or osteopenia, and muscle weakness, stomach reflux, abdominal pain, bloating, alternating diarrhea, constipation, nausea and vomiting, nasal congestion, shortness of breath, localized swelling of the mouth and lips, headache, fatigue, numbness or tingling in the hands and feet, brain fog and memory loss. These symptoms are like those experienced during anaphylactic shock. Some people with MCAS also go into anaphylactic shock when triggered. The symptoms experienced are due to the release of mast cell mediators, histamine, tryptase, leukotrienes, prostaglandins, and many other mediators. The symptoms tend to flare up and calm down in response to triggers. Triggers can include food, fragrances, infections, hormones, exercise, temperature changes, and some medications. MCAS gets diagnosed when at least 2 organ systems are affected. There is also an increase in blood tryptase levels above normal when experiencing symptoms, and finally, if there is a response to treatment. Mast cells release many mediators, so treatment focuses on preventing mast cell degranulation and blocking the mediators' actions. The standard treatment includes avoidance of triggers and also antihistamines, mast cell stabilizers, prostaglandin, and leukotriene inhibitors. Some people will experience more severe reactions, such as anaphylactic shock. These patients can receive anti-IgE therapy and carry an EpiPen. The reason people develop MCAS is not known, but it could be due to a genetic predisposition to accumulate mast cell mutations. These mutations make the mast cells more reactive to triggers than for a regular person. There is also an association between families, but the specific causative inherited gene or genes are unknown. There is also the idea that autoantibodies play a role. Autoantibodies are antibodies that recognize self-antigens. These could be activating mast cells. Systemic mastocytosis is a mast cell cancer. The symptoms and triggers are identical to MCAS, but there are more mast cells throughout the body with mastocytosis. More mast cells mean that there is a higher risk of anaphylaxis. The increased number of mast cells is due to a clonal growth of mast cells from a mutated cell in the bone marrow. Because of this, the mast cell clones can spread through the whole body. As a result, there can be an increase in mast cells in many organs. Diagnosis of mastocytosis is by several factors. One is having a blood tryptase greater than 20 nanograms per ml. A high level of plasma tryptase indicates there are more mast cells than usual in the body. Second, a bone marrow biopsy should show that immature mast cells are present in groups of more than 15. These mast cells are likely to have a spindle shape. Finally, more than 80% of patients have a mast cell stem cell factor receptor mutation, KIT D816V. This mutation makes this receptor always active. Yet this mutation is not the underlying cause of the disease, so the mechanism for developing mastocytosis remains unknown. The treatment is the same as MCAS. The aim is to control the symptoms, but as there is a higher risk of anaphylaxis, patients will carry an EpiPen. There are also newer drugs for patients with advanced mastocytosis. These drugs target the stem cell factor receptor to decrease its activity. As a result, they help lessen symptoms in these patients. Subscribe to ClevaLab to learn more about human biology.